Thank you, thank you. Let me start it again. Hello, everyone, and thank you for taking the time to join this talk. Welcome to Quality Improvement Lecture Series in a joint CME program by Larkin Community Hospital and Florida Medical Association. I appreciate both Larkin and FMA for supporting us in planning for this gathering, and a special thank to our team at the research department that worked hard to make this happen. I'm Dr. Sima Marzban, physician, PhD in health system administration and MPH in healthcare leadership. With more than 2 decades of experience in practice, academic research, and teaching, and also executive responsibilities. What I have learned over the years is that there are always opportunities for evidence-based improvement in every clinical setting. There is no ceiling to improvement. And if we master the scholarly knowledge and tools for improvement, I believe there is a lot of opportunity to do that. I believe that the research that doesn't lead to positive changes and improvements and only results in the articles publication is not effective in improving the environment around us. Quality improvement bridges the current issues, potential solutions, and the research effort. That's the benefit of quality improvement, because it connects our priorities and our issues and problems in our departments with the research projects. So the research publication in that way, the research report in that with quality improvement would be meaningful for improvement, the workplace around us, the practice that we are doing, we are trying every day. And we can see the results of the projects after putting a lot of efforts and time and energy into research. We can see something change, something happened in our workplace and in our practice circumstances. It's an honor today to have the opportunity to talk about clinical setting quality issues to the Larkin program directors, faculty, medical trainees, and esteemed audience from outside of the Larkin who tried the CME lectures now or later. In this 5-hour series of lectures, we will discuss these areas. First, how to identify the quality gaps. Second, how to create and support the change culture in order to make changes achievable. The third hour will go to discuss what are the effective key drivers and strategies for change. And in the 4th hour, in the March, we will discuss how to plan for an actual change in our medical education or practice. And then in the last hour, we would have a discussion on how to apply tools and measures. How to apply tools and what are the helpful measures to prove that our quality improvement intervention is the right choice for our context. And making changes sustainable would be a part of all sections of our conversation. So this is a summary of what we will discuss in these 5 hours. We all know that quality improvement plays a remarkable role in the accreditation and graduation of our residents and fellows. In these presentations, I want to share the quality improvement skills with you to take a leading or mentoring role for the medical graduates and support them and assign the projects that are priorities of the clinical program. And beyond that, to advance the approach and motivations actually to change and improve our practices and workflows. I know there are participants of the meeting who experience some defects in daily activities and occasionally express dissatisfaction when they are talking about their experience. That's the point that a quality improvement project can be started. Quality improvement focuses on problems and inefficiencies or meeting new medical needs. So if we are constantly talking about gaps, issues, and problems in this lecture, and in other lectures as well, the other 4 hours that we will discuss on quality improvement, it's because quality projects start with a problem, with a real problem. Some of us are reluctant to change and accept to be a part of the shortcomings and the defective circles that we have around us, but always those win who can make changes in the profession and business in line with environmental developments and advancement. If you gain the ability to make a difference systematically, you'll welcome it. You'll welcome it through yourself or your team. These sessions are a great opportunity to share our experiences on how to improve the quality of the treatment environment in which we work through quality improvement projects. Usually when we talk about quality improvement, the first question is, what are potential topics to work on them? What are the best topics, the best issues, the best areas to work on them, and put them as our title for quality improvement project? Where to start? And what is the difference between these projects and other clinical studies or research projects? I like to start our series of quality improvement discussions with examples of the quality gap, and each gap can be a topic for quality improvement project. So if we know what are quality gaps, then as a program director or a faculty or a person, a member of a clinical team, we have a clear picture of what are the best areas that we can assign our colleagues and our team to work on that area. Let's start our 5 hours talk with a classification of care quality gaps. In this discussion, we'll try to address the quality gaps with meaningful words for clinicians and academic faculty. Okay, as you see here, care gaps from the perspective of the patients and families, evidence to practice gaps, data gaps, medical and IT platform gaps, understanding patient and the gaps that are potential in this area, social determinants of health, and the lack of knowledge and information about the patients in terms of their social determinants can be other quality gap in our practice, preventive screening gaps, healthcare equity gaps, wellness gaps, appropriate use of medication, the gaps in this area, accurate diagnosis and treatment and patient management gaps, patient education gaps, teaching and education gaps, and interprofessional teamwork, the defects and shortcomings in this area, communication gaps, data recording and utilization gaps, leadership gaps, management gaps, utilization and productivity gaps, and process workflow gaps. Now you have 18 categories of gaps that all of them can be a topic for quality improvement in our department. Let's move on to learn what are those gaps. The first thing that we want to focus on that in this presentation is what's the difference between quality and quantity of care. Always when we report our services to a supervisor or to an investor of a clinic, hospital, or somewhere else, or it shows our activities and efforts in our department is number of visits and procedures, number of surgeries. So numbers are talking about our performance now, but the quality of clinical care is something else. Do we measure the clinical quality? Let us know, let us understand, let's figure out. Explain what are examples of the clinical quality measures and potential gaps. Is it measurable? Let's figure out in this presentation. Locate different dimensions of the care that reflect the quality, recognize data resources that are instrumental in identifying the quality gaps, and understanding the gaps in various levels, in different layers and the levels of the system. For example, gaps in systems level, gaps in administrative level, gaps in performance level, clinical performance level, gaps in workflow, in teaching, in mentoring. Let's start with clear examples about those. It's important to understand from the point of view of who we target quality. Sometimes there are differences between how physicians, policymakers, investors, and families define the care quality. For investors, what's the quality? For investors, what's the quality of care? It's benefit, saving the money and producing a lot of services and reputation. For physicians, equip and a smooth environment and support. For insurers, lower costs and expenditures. For a patient, what's the quality? Think about it. What's the quality from the lens of a patient? Accurate diagnosis, am I right? On-time services, am I right? Helpful information, effective treatment, and pain relief. If you look at the patient and his interest, anything that diverts the patient from the benefits of treatment and increases its costs or waste, including time waste, is a quality issue, is a quality problem. But the quality standard is not always the same for the patient and other stakeholders. It's not the same. So we should focus on from the lens of whom we are looking at quality. Now let us look from the lens of patient. From the lens of a patient, when a patient is at age that is risky, and fails to comply with recommended screening or preventable care to prevent some comorbidities, adverse events, or conditions that are hard to treat later, that's a quality gap. A patient diagnosis that is not shared with the PCP, primary care provider, or a specialist for another related condition is a failure, is a gap. A patient cannot schedule a behavioral health appointment in a timely fashion and leaves us for another provider is a failure. The patient that doesn't follow recommended prescription guideline for a chronic condition because of economic access or low information or lack of understanding of the condition, non-adequate and insufficient education about the condition, when they fail to comply with the protocols with our recommendation, it's a failure gap. A child who is not scheduled for regular well visits and vaccinations is a failure. A patient who is not able to find the care they need in their network or area is the failure. Please look at here, from 50,000 people who are eligible for breast cancer screening, only 50% have met the preventive screening procedures. And from 100,000 of the people with colorectal cancer screening who are eligible for this type of a screening, only 50% have met. So the half of people who were eligible for this missed the needed and required treatment and solution to prevent their latest or future conditions. That's a failure, that's a gap, and we can cover these gaps as a quality improvement. Just focus on the facts in our departments, on these facts and figures from EMR, from EHR, to understand what topics can be our quality improvement project. Let's see what is care quality and what's the definition of care quality. When we are buying a cell phone, we know what's the quality of our cell phone. We can understand that. It's something tangible for all of us. What about care quality, healthcare quality? Let us define it from AHRQ perspective. That is a reputable organization in the United States that has defined care quality when the care is safe. It means avoiding harm to patients. Avoiding harm to patients. Effective, providing services based on scientific knowledge. The last updated the standard and protocols of the care. So if we can provide the care with evidence-based knowledge, evidence-based protocols, clinical practice guidelines, updated ones from up to date, that's an effective care that can benefit the patients who are taking benefits from that special care. Avoiding underuse, avoiding misuse, and avoiding overuse is a part of effectiveness. So overuse of procedures is a quality gap. Underuse of procedures is a quality gap. And misuse of that because of our shortages in our knowledge is a quality gap. Patient-centeredness, providing care which is respectful and responsive to patient, in which circumstances, in which manner, when we personalize the care for special needs and values and social determinants of the patients. If we understand their preferences, their needs, and their special cares, we can provide a patient-centered and personalized care. The care which is timely, reducing waits and harmful delays. Efficient, avoiding waste, including waste of equipment, waste of supplies, waste of ideas, waste of motion, waste of energy, waste of staff, waste of time. All of them are waste. So efficient care is a qualified care. And any gap in these areas can be a quality improvement topic. Equitable care, providing care that doesn't vary in quality because of personal differences like gender, ethnicity, geographic locations. This is the defined care quality, and any gaps in each level can be a quality gap. A practice gap is the difference between what is happening right now, and what should be happening. So this is the practice gap. In action, practical work, not in knowledge, not in our skills, but in action. What happens to patients in the real world? So, and we should prove and validate the gap. Because of that, I asked the residents that are coming to our office with some quality improvement ideas and topics. They're talking about the gap, but I'm asking always, how can you validate the gap? How can validate that gap exists? Do you have some data and facts from your department? Have you reviewed the EHR and EMR about the number of the patients who are experiencing that gap? Have you reviewed the evidence, relevant evidence? And in which area that gap exists? Is it in knowledge area? Is it in a skill area or in practice area? Why do you think the current state exists? What is the underlying or root causes? Root causes are always important. So let's be deeper in these details. The first category of gaps that we mentioned in our first slide was evidence to practice. No, it was patient-centeredness. This is the second category, evidence to practice gap. What does it mean? You know that always we have a time gap between discovery of scientific data about a solution and the widespread medical practice and publication. There is always a time lag. So knowledge translation means describing and connecting those scientific discoveries and studies with our medical practice. How we can connect our department and our practice, everyday practice, daily practice, with evidence when we combine elements of research, education, medical education, and quality improvement. And also the data that we have in our databases. If we can combine these elements when we are educating residents, combine the education with research items and components, and with quality improvement in action, and with working with the data that is available in our databases, in our MedHouse or EMRs, that is the way that we can shrink the lag. We can shrink the lag. You know, the books, publication of books have always several years lag with when the studies discover something about medical advancements. So we can shrink that lag. We can reduce the time waste by combining elements of research with our medical education. The failure to translate medical education into clinical practice and decision-making is a quality gap. If we don't have journal clubs that appraise and search and review systematically the evidence in our department, that's a quality gap. If we don't have evidence-based journal clubs, grand rounds, didactics, evidence-based with appraisal skills and competencies among our residents, because residents shouldn't accept all type of available evidence. Evidences that are available in different databases should be appraised critically in terms of quality of evidence. Those are skills that they should obtain and gain during their education. And misuse, that is medical error, underuse, lack of our practice compared with the proven therapies that are available in the real world, and overuse of the solutions can be 3 types of gaps that could be the result of our gap in evidence to practice strategies. Gaps in data flow and feedbacks from clinical team. EMR data items that are missing. If we need elements in our EMR, elements of data in our EMR, that we don't have access to them right now for better decision-making in our practice, that's a quality gap. Interconnected and interoperable data. It means the results of the lab test, the results of the pharmacy, the results of the consultations, and our care planning is not available to people who are working on the patient at the same time. So they don't have access to the data on time. That it means interconnectivity, it means interoperability of the data platforms, time lags when data are needed for decisions, visibility of data for the team members and patients, in-house clinical quality reviewers. Advanced hospitals and organizations have clinical quality reviewers. Randomly, they check the quality of the steps. And that is not something to evaluate and punish the people for quality gaps. That's because they want to understand, to know, to realize, recognize what are the quality gaps and prioritize those areas for improvement. And patients' non-clinical data, if we don't have access to that and we are only focused on clinical data, that's a huge quality gap. We will discuss it later in our slides. The fourth category is primary care practice gaps. We know that primary care and primary practice wants us to have a holistic healthcare, wants us to manage the chronic disease better. How? Through informing patient, through connection with connecting them with the necessary references and supportive locations and touch points for healthcare, with hiring the level of comfort among the patient, with transparency of entire health history, lowering overall health costs, and catching health issues earlier. That's the meaning of primary care, preventive care, and health-oriented care instead of disease-oriented care. That's the meaning of primary care. Any gaps in this area means that we have problems in quality. A female patient age 50 with a family history of breast cancer who doesn't get annual mammogram, a hypertension patient who doesn't refill the medication for blood thinners, a child who isn't scheduled for regular well visits or vaccination, a mental health patient who seeks help in the emergency room instead of mental health clinics, or wellness status evaluation in their organizations. That's the thing that primary care can prevent it, and our focus on that can prevent it. So let us find these issues in our departments and assign residents and faculty to work on these areas instead of the topics that they are finding from different articles in other journals, in other organizations. They can prioritize and they can realize and recognize our issues in our system, then work on it and spend their time on it. The next category of gaps is in our understanding of patient and community. Please focus on this category. What are the most relevant needs of our patients? Do we collect the data and ask our patient to gather this type of data for our patient needs and preferences? Do we have any way, any ongoing process to access to this type of data? What are their communication and care preferences? We are calling patient and leave a message for them in their voice box. Is it their preference? Is it the way that they prefer to communicate with us? How do they want to engage with us? What information do we already know about them? We already know about their signs and symptoms. What about their social determinants of health? What is social determinant of health? Social determinants of health include all these items that I'm talking about. The first one, health literacy, education, housing, employment, level of income, family members. Employment situation is very, very important. Security, nutrition, food security. All of those are social determinants. And always they influence the medical condition that patient is struggling with. If we don't know the social determinants of the people, how we can treat them on time, how we can engage them with their care, how we can empower them to care themselves with the right strategies and right medication. How is their experience with our services? You see here, this is the Net Promoter Score that shows when we ask patients from 0 to 10 to score us. From 0 to 6, when they check mark, it means they are unfavorable of our care. When they check mark 7 and 8, it means they are passive. And only when they check mark 9 and 10 and score us in these categories, they are recommending us. So it's very simple, but it's not enough to know how they score us. We should understand how they are thinking about us, about the care, about their condition, about the treatment and care planning that we have planned for them. All of those areas should be understood. How we can understand those thinking, belief, and thoughts of the patient to improve our practice, to stand among our competitors in the market, to have a clear picture of the patient in our practice through this. This is a patient journey map. It's a tool for other industries. They have checked it, examined it decades ago. But it entered into healthcare industry recently, empowers us to understand how our patients move around different steps of the care. How is their emotions, anxiety, fear, concerns, worries, in different steps of the treatment. This ART is antiviral therapy for AIDS patients, AIDS affected patients. So when they are in the suspicion phase, anxiety, doubt, and fear. And what would be their actions in this level when they feel fear and anxiety? What is their actions? What are the actions? Understanding the patients can result in understanding when is the key time to intervene. You see, when we understand our patient, we can design the best time for intervention, to educate people, to inform people, to support people, to keep them around us, and not to allow them to leave the network, our department. That's the way that we can understand our patient for having loyal customers. This is the other tool, Cancer Experience Map. Again, it shows different touch points of the care, the pain points of the patients when they are in the shock and crisis, and feeling concerns and fears. This is the first step that a patient has been diagnosed with cancer. What would be our strategies informing patient about the stress and crisis? Empathizing with emotional concerns and talk directly with them. And then what would be behavioral factors here to help them, assist with them to accept the diagnosis? What in the treatment decisions, if we know them, we will put some strategies in place to getting needed information and support. And then in the active treatment, to empower them for self-care. And in end of active treatment, we can empower them to adjust to new life, and re-engaging and rejoining to the community and the routine life of their families. So these are the tools that can help us. And our quality improvement projects can work with these tools and toolkits and illustrations. We have supposed a fellowship program, education program with patient experience mapping, patient journey mapping in chronic inflammatory diseases in dermatology field that Dr. Skopit guided us and coached our team to apply for that fellowship program. So we can assign our people to work on these areas to understand people well and develop advanced solutions for their care. Okay, 360-degree insight of patient in healthcare matters. And we talked about these items in last slides. Let us move on to the other layer of the quality gap, disparities and equity gap. As you see here in different publications, we can find different measures of disparity. What are disparity measures? Greater use of a solution, psychotherapy, not pharmacotherapy among Black population. It can be a disparity gap. Percentage of use of adequate antidepressant medication among minorities compared with white population. Using a combined solution, combination of blood pressure monitoring and tailored behavioral intervention among a population group, white patient versus non-patient. But we should measure these items to be able to prove that there is a disparity, there is a quality gap. Difference between hemoglobin A1C testing between a population group with other population group, or higher rates of smoking and effectiveness of the solutions among one population with other population. Disparity in lipid profile testing among what African-American people with white population, and even differences between healthcare coverage percentage among Hispanic population and other population. Even the life expectancy rate at birth. This is the things that we can measure in our departments. Very simple, from our EMR, from EHR, and these are these are equity studies that can describe well.
No?
Okay, let me ask my first question, and please unmute yourself in 5 minutes and answer it. How can we measure disparity in our practice at hospital or clinics? Is there any cross-sectional project or ongoing strategy to measure the disparities? And how do you see it? EMR can help us to gather those measures. Please unmute yourself and reply this.
Well, we can use the EMR to trace the people who were recommended some intervention based upon their age or category, and they didn't went through in the further follow-up.
Thank you. So is that feasible easily or not?
It would take some effort, but I think that's feasible to do. Like we can trace the people, put some filters in the population, and we can come up with the data.
Great. Thank you so much. Thank you. And for because of limitations in our time, I request one another person to share their ideas with us. Is that something feasible to your opinion? Okay, let's move on another group of gaps. Gaps in workforce wellness and workplace status. This is another group of gaps that we can put them as the quality issues, a topic of our project in our department, wellness issues among our clinical team members. Because of that, we developed the Larkin Community Hospital Wellness Questionnaire to collect the data about the last 3 months experiences, any increase in any of the following issues that are relevant to mental health status, and what are the top 3 work-related stressors over the last 3 months. So with collection of this data, we are able to prioritize the issues in our workplace and improve them. It can be a part of our efforts in our departments, in our clinical programs to work on these issues as the quality improvement issues. The next group of gaps focus on inappropriate use of medication, use of medical device, use of technology. For example, the current status is new monitors have been purchased for the ICU. Our clinical team should know how to set up and use the monitors. This is the desired status. That's the gap that we want to state. So a statement of the gap would be a part of quality improvement project. We will discuss it in the next hour, in the next meeting and presentation. So the identified gap is our clinical team currently do not know how to use the new monitors. What are the gaps? The knowledge gap, haven't had exposure to new monitors, so do not know. The skill gap, don't know how to use the new monitors. Practice gap, haven't used the new monitors in their previous patient care. How we validate and we can prove that the methods that used to identify these gaps with observation, direct observation. This is another gap, using a type of face mask, non-rebreather face mask for pediatric patients. So again, the identified gap is frequent, inappropriate, non-rebreather face mask application for pediatric patients in respiratory distress. So this is the gap in the area of a skill, lack of a skill in correctly using and applying face mask. And direct observation is the way that we have identified this gap. The next group of gaps are the gaps in diagnosis. This is where that we as clinicians and physicians like it. The gaps in diagnosis, the gaps in patient management. We like to work on these areas to improve the practices. And this is a part of accreditation measures as well. How do you work on your practice data to improve your practice, the quality of your care among your patients? So this is the area that we can work on it. How? These are examples. Inappropriate techniques and use of ultrasound. Lack of prompt or early recognition of the medical condition. Inappropriate management of a disease. Application of wrong or incorrect techniques. Not applying current clinical algorithm. Do we have algorithm in our workplaces? Clinical practice guidelines, standard practice protocols, at least for the most prevalent conditions in our hospital. At least for most prevalent conditions in our department, we should have some standard algorithm, clinical practice guidelines, because we have a teaching environment. And sub-interns, interns, residents, resident year one should be familiar with the standard protocol in our department. Challenging to stay current with rapid advances in the field, new drugs, treatment not happening in a timely manner. So time is a quality gap in the treatment, lack of experience in managing or treating, lack of education or training. Training is inadequate, inefficient, out of date. Condition is difficult or challenging to diagnose it. Poor understanding of the condition, and many other examples about that. Any of them can be a potential topic for our quality improvement. Then the next group of gaps are gaps in patient education. Patient needs for understanding the condition. All of us know that, but do we have developed protocols, sheets, and navigators for patient education? What are our communication mechanisms? Are they effective? Staff education on how to educate patients. We want our staff to educate patients, but how? They need protocols, they need material, they need sheets, they need education and training programs on how to educate patients. Educating patients like educating teenagers, educating children. It needs an art, it needs skills, it needs knowledge on how to educate them. So nurses inherently are not educators. Physicians inherently are not educators. They need to educate them about patient education, how to educate the patient. Patient engagement with the care planning. giving a responsible role to patients. They shouldn't be passive in their care activities. They shouldn't be passive. We don't like the paternalistic approach of the care, that they are only listeners to physicians and they should comply with and adhere with. No, this is not the modern concept and modern theories. The modern theories tells us that if patients are engaged, are valued, are empowered to engage with the care, they will care themselves based on our recommendation. They will engage in our decision, shared decision-making. This is the shared decision-making process, not just telling the patient what to do. They don't do the thing that we are prescribing because we haven't informed and engaged them in the process. So empowering patients to improve health outcomes and self-care efficiency. You see here in a quality improvement project in head and neck cancer unit, they incorporated and included these activities in their quality improvement project. Development of multidisciplinary patient and staff education protocols, development of patient education sheets. This is very important to be a part of our activities, our quality improvement efforts in our disciplines, in our clinical programs. The next category would be, because we are a teaching hospital, Larkin Community Hospital is a teaching hospital, so we need to identify gaps in teaching and education strategies and performance, to understand what's the difference between traditional curriculum and modern curriculums. Traditional was teacher-centered. The modern is student-centered. Traditional information gathering from different resources. In didactics, people are gathering resources, they're gathering some facts from different resources and provide a presentation. But the new approach is problem-based presentation. You see here that quality gaps are problems and priorities of our practice environment. So I put that as the topic, quality gaps. I could talk a lot about what's the quality and what's the quality concepts from different years, what's the evolution and history of quality, and many things around quality. But that's not the thing that we need for quality improvement. We need to realize what are quality improvement in our hospital. So discipline-based has changed to integrated. And you see integrated systems learning activities here. Just an example, for a child with anemia caused by hookworm infection, the patient's sociocultural characteristics were analyzed, including social determinants of health, malnutrition, hygiene habits, life in rural zones, and his or her relation to the health system in Colombia. Those are aspects of the care that we should include when we teach people and provide an opportunity for our residents to learn in an integrated systems learning approach. So community focus, systemic approaches, and integrative learning. Those can be gaps, can be topics of our quality improvement projects in our departments. And this is where the residents address that. Only 9% of residents strongly agree. This is from an article, not from Larkin. Only 9% of residents strongly agree that residency provides sufficient training in knowledge when to refer patient. And only 8% strongly agree that residency program provides sufficient training in what information to provide the consulting physicians. That is the role of resident surveys. They have a lot to say for quality improvement. And as a faculty, we have access to those resident survey every year. So we can identify what are the quality gaps and focus on those, and then ask people to work on it, to spend the time on it. And this is the supportive document for that article. The second question would be, how can we assess the educational gaps of our departments at Larkin? Please, faculty, I'm eager to hear your voice about this. Where is the best place to discuss the program's gaps in knowledge, skills, or practices? Do we have clinical competency committee in our department? Please unmute yourself. Okay, others, can you contribute to this?
Maybe during didactics.
That's great, yes. That's an opportunity. That's an opportunity to talk about it.
If we set up like a certain amount of time to discuss with the residents and the attendings, if they interact with them and talk about places where improvement can be seen and take it from there.
Yes. If the culture of change and culture of assessing the gaps in the department is empowered and supported by the program director and program faculty, that's the best opportunity to talk about these areas in didactics and hear about many things from the residents, from faculty attending, even from patient representatives. If you invite patient representatives in those meetings, that would be the good opportunity to hear their opinions, their views, their preferences, their experiences. Positive or negative, no matter. It values for us to have a change. Thank you so much for your contribution. Okay, the next group would be gaps in interprofessional collaborative teamwork. That happens usually in operation room, code blue, consultations with other specialists. So anywhere that we invite other specialists to work with us is a type of interprofessional activity, and interprofessional activity is very important because it brings collective leadership, decrease the pressure on individuals, and disperse the pressure on the group and responsibility for the group. Role clarity is very important there. Trust is important. Ability to overcome personal differences and ability to overcome adversities is important there. Communication among clinical team members is the other care quality gap category, because we are discussing cases during phone calls, runs, meetings, IT platforms. So there might be many wrong or missing component, misunderstanding of the communication, gaps, overlaps, conflicts in verbal talk, missed information, misunderstanding, wrong information. It might happen. Language barriers, accent, diversity, abbreviations, errors, doses, errors, communication mechanisms, written, is it written or verbal, double check protocols, incident reporting, learn and share, patient communication, all of those goes to this category. So we can work on these areas for quality improvement. And you see here that 1 out of 5 patients who read visit notes report finding mistakes. So lack of data items, poor use of the data, incomplete records, reduction errors, lack of alerts, charting errors, those are gaps in quality of the care. Okay, this is very important because one of the most challenging root causes of the care quality is leadership, management, and resource utilization. So the leaders who care these areas can support change management in their system. They inspire commitment among employees. Managers who recognize and reward employees' achievements are able to inspire commitment from their subordinates. Such managers publicly praise others for their performance. So if you have someone in your department that is spending a lot of efforts on research and making a difference and changing some a problem, an issue, problematic condition, it's the time to support those people, to support research liaisons if they are working well, if they are, for example, creating committees in the department and they are gathering other people to work with. It is in the systems level leadership, high level, top level, or the leadership in the programs and departments. Leading employees is important. If you want the change, if you want the advancement, it's needed to lead the people and develop their capacity and inform them, and a strategic perspective that is a long-term perspective. It's not only planning for today or this year, it's a long-term planning and self-awareness. Those are key gaps in the leadership that we can target, and we can put them as our quality improvement topics. And this is the last one. This is the last category of quality gaps that are process, workflow, time, and motion gaps. You see here that there are many tools that we can document the process workflow, and we can help our department about practice guidelines, protocols, procedures, trigger tools, triage. If we don't have none of these, we can work on them as our quality improvement projects. Okay, and this is a sample of the quality improvement process workflow. And the last question, which category of gaps do you prefer to select or work with? Systems level, that is leadership, policies and rules, or operation level, that is clinical procedure, outcomes, or medical training. Please unmute yourself. This is the last slide.
The second is more feasible to achieve because it's it can be achieved quickly than the first one.
Okay. You are right. Operational level is feasible, but the system level has more influence. You know, that's the difference between these two. So thank you so much for joining this lecture. Again, I want to wrap up my discussions with bringing this slide that we reviewed all of these 18 categories of practice gaps and quality gaps. And thank you for joining again. Have a very nice day.
Thank you,
Dr. Seema. Thank you, Dr. Seema.
Thanks all of you that have joined, and you know, you allocated your time. Particularly thanks Dr. Scopit, our program directors. I don't know, do we have? Yeah. Okay, thank you all for joining this presentation. And I'm hopeful that now you are able to apply these skills in your departments. Please let us know, let us learn from your departments after this presentation. The communication will be open. So we are at the research department to listen to your valuable cases and experiences in your departments. Thank you very much. Have a very nice day.
Thank you so much.
Thank you, Dr. Marsban.
Thank you so much, Dr. Marsban.
Thank you everyone for joining.